break. Thank you. And I hope our online audience are back as well. So we're going to change things around a bit. So we're going to skip the recap of the case example for now, and we're going to go directly into Saskia DeWitt's presentation on translating adult renal impairment PK data. So I'd like to invite Saskia to come up here to give her presentation. Thank you.
Well, hello again, everyone. I hope you won't fall asleep. I have some issues with my jet lag, but the coffee may help. And putting it up on the stage right away also helps. So I kind of continue on where I started this morning. And this first step is how to translate adult renal impairment PK data, the academic and clinical perspective. Well, again, extrapolation from adults. This paper was written with colleagues from Leiden University. I'm a clinician, I'm a clinical pharmacologist, but I'm not a super modeling expert, but they are. And together we've been working to figure out how you can actually better model data and predict doses in kids. And what we've done in this project, and I must say that they get most, I think 99% of the credit, is that they actually wanted to put more or less an end, or maybe start a discussion on when can you extrapolate just based on the Lambda-3 on linear rate, or when should you actually go and start using PBPK modeling, on the assumption that most changes in physiology, as I presented this morning, occur early in life, in the first 1 or 2 years of age, and after that, well, it's mainly size. So in this review, they used PPK modeling as a standard for many drugs. A lot of theoretical exercises were done, and what you can see is that for most drugs that are renally cleared, this is for renally cleared drugs. The manuscript also has similar tables for metabolically cleared drugs. Is that dependent on the not only if the drug is renally cleared, but also if it's bound to albumin, which makes sense, and also if is a transporter substrate. It really depends how you can extrapolate till which age, and or if you should actually think about using a PPK modeling to actually come up with a dose. So thinking about this, then you could also may be able to extrapolate the dosing of drugs that are renally cleared in kids with renal insufficiency based on this premise. So going down all the way using BSA to very young, and then not taking into account the, for example, the renal transporters may get you really, ontogeny really get you into trouble. Again, we discussed this morning, so I won't go into this. But it is, it's kind of important to realize in the modeling and in the extrapolation from adults to children, what kind of GFR measurement or what kind of renal function measurement is used as covariate in all these models, because that really determines for you to evaluate what if you read these papers, what the impact of renal function is in relation to age. And I'll show you some examples of where this gets a bit complicated and where you really have to not only read the abstract, but really go into the paper. Again, I've showed you this already, and again, the interplay. And I first would like to start about a paper, one method of how we figured out the relationship between the AKI or CKD and in pharmacokinetics, and that's this paper, and it's very simple, non-parametric pharmacokinetics. The clearance of lisinopril was scaled allometrically, and you can see this on the left-hand side of the graph. And there's a very clear correlation with eGFR, based eGFR in this case based on the old Schwartz formula. When you then look at the AUC. The AUC is actually higher in kids with a lower eGFR, but they do not advise to change the dosing because the therapeutic window is so wide. At the same time, you can indeed see that there is a relationship. At the same time, there's no impact of age on the clearance. And in this specific paper, and again, if you then say, okay, there's no relationship with age, then well, we can just extrapolate. We can use eGFR, and there you go. But only older children were included. And this is something also when I read papers on pharmacokinetics in kids and extrapolation from adults. One of the big messages I have is, please look at the data that are there, and please, when you report things as industry or as regulator, please put the age ranges there. Because when industry says, well, there's no impact of age on pharmacokinetics, well, then they've usually only studied up to 2 years of age and not below. And then there is impact of age. So when you talk about extrapolation downwards, this is super important information that usually is buried somewhere down. Going further, a POPPK model of valganciclovir. I don't know if the people from this study are in the room or are online. There's newer data from valganciclovir, but I also wanted to show this as another way of how dosing was done in this study. So this is a study of valganciclovir in pediatric solid organ transplant patients with normal but also reduced renal transplant function, and they dosed based on BSA and creatinine clearance, again using the bedside Schwartz method. Kids from 3 months to 6 years of age. So here again already you have kids there who have clearance that's probably affected by age and by GFR, but because they dose on BSA, and we know that when you go down lower than 2 years of age, BSA will overestimate clearance, or will result in a too high dose in younger kids because their creatinine clearance is low. By putting this creatinine clearance here in the calculation, you're probably going to be okay, but you cannot tease out the impact of age and the impact of renal failure. You can look at creatinine clearance, but not what is the normal creatinine clearance of age versus what's the impact of the AKI. And I think that's also one of the difficulties when you look at this kind of study results, but also when you design your study. So here you go. This is the post-hoc estimated valganciclovir AUC. So they've done a POPPK study, and then based on the POPPK pharmacokinetics, they have estimated what AUC you would have. And then you can see that independent of body surface area, your AUC is stable. But again, this is based on the dosing, including the creatinine clearance. And similarly, when you put in the eGFR, you'll have a slightly lower AUC, but I don't think that's statistically significant. But it goes also all over the whole eGFR range, again, because the dosing was also based on BSA. Another approach and another way of how data were analyzed and then predictions could be made on dosing was for milrinone. Different setting, not CKD, but AKI, so children in the intensive care unit, where milrinone pharmacokinetics was collected. And what they did here in the modeling of the POPPK is they estimated, they made an equation for the clearance based on the body weight and a maturation factor. So it's body weight to the power, I think in the end it is 0.75, and they also put in a maturation factor. And the maturation factor actually takes into account the maturation of, in this case for milrinone, which is a renally clear drug, of the kidney. So, but to add to this, then they also put in if the patient had AKI and which stage of AKI. So they defined stages of AKI based on age-normalized values, and then they also put this in the model. So here you can tease it out, and what you then see is the clearance based on AKI stage 0, 1, 2, or 3, so different severities. On the x-axis, the age, the HA months, and the allometrically scaled clearance. And then you can indeed see that the clearance increases by age in the stage 0, so there's no AKI there. But then it also increases in stage 1 and 2 by age, but there's AKI, and the overall clearance is in general lower. So here you can see, now I have it's done. So you see indeed there's an interaction between age and with and the renal failure, but the data, in my opinion, are not enough to really look. Is this proportional to what you will see in adults, or is it different from adults? And is there indeed a difference when you are a say 1 month old, or if you are a 9 month old in the impact of the AKI on your clearance? I think the data are not enough to do this, but I think it's an example of how this kind of collected data could be used, and also maybe published data from many other drugs which are similarly used, if I think could be pulled and see if you see similar patterns, and then get a better idea. The next step, and I already alluded to this earlier, is PBPK modeling. This is a flow chart from this paper from 2022, and the drug is, I forgot the name of the drug daptomycin. It's an antibiotic, and they developed a flow chart of a stream in PBPK modeling, where they first developed the PBPK modeling for regular adults and healthy kids, and then they went down to PBPK model for renal impairment, and then they combined it to make a PBPK model of kids with renal impairment. I think the flowchart in itself, I think, is super helpful. That's why I put it up. The big problem with this specific model is that they present how you should dose the daptomycin, how you could dose it, and what the impact of the renal impairment is in children of different ages, but they had no data to verify the model. So, personally, I'm a fan about how they did this, and I think it's one of the ways we should start thinking about this, but it is not definitive, and I think, again, you have to be careful to use these papers, go and read the abstract and take them as evidence, because I don't think they are evidence. Then there's another study where they used captopril, scaled it again to pediatrics, but also, and I think this is interesting, they adjusted the PBPK model, and they also put in the other PK processes, so the oral disposition, volume of distribution, that are also affected by renal failure, and they put it in this PBPK model. Interestingly, clearance was scaled with BSA and not mechanistically, which, again, if you go down really, really low in kids, that might be an issue, because there's no correction for the maturation of all these different processes. It wasn't necessary, because the age range was 3.5 to 18 years of age, but if you would use this model and you would try to do it for a lower age or for a similar drug, then you might get yourself into trouble. Again, as I said, older children, it's really nice predictive. It's on the x-axis the ratio of the observed versus the predicted pharmacokinetic parameters, and the clearance Cmax and AUC are all relatively well predicted. Again, the limitation is that they did not include younger children. They also did not include that in the PBPK model. The title says daptomycin, but this is a lamivudine, I can't pronounce it, two HIV drugs, which are given in a combination therapy from the group from our pharmacy department, where we do a lot of studies, PK studies on HIV. And the question there, indeed, a lot of these children with HIV have chronic kidney disease, and we developed a PBPK model for these drugs. Similar problem. We had not a lot of data to verify the model, but then my colleagues, was again not my idea, my colleagues thought, well, Velc and cyclofer is also renally cleared. We do have data, CKD data. I showed you before, these data have been published by other groups. And if we then validate, build our model and then validate it based on these valproic data, and we feel that the model performs well, then we can use it also for these other drugs. And I think that's another way, or how we could develop kind of like standard PBPK models, so that they are verified for these specific pathways in children with CKD, where we do have data for. I know Gita has lots of data from children with transplants of several drugs, and others also have these data, and these data have also been published. That then your compound that has similar GFR and or transporters, then could be put into that model, that at least you have an idea. So maybe I went a little bit quick on this. One of my main take-home messages, I didn't really go into extrapolate from adults to children, because I assumed you all know this, because you're all already in this field. But I really dived into the data that are there and how you can look at it. Consider the age rates of interest. And we already discussed it, but again, after the discussion this morning earlier, I thought, well, we haven't really delved into the less than 1 year of age. We have kind of came to a discussion with Kay and how maybe even from the term children, for the preterm children, we haven't gone into this in extreme depth. And I think that's super important, because we don't have a really good idea how it works. So if you extrapolate using either BSA or linear weight and or proportional, and or you do a PPK model, at least look at your PPK model or a published PPK model and see if maturation is really included. It's really mechanistically included, because otherwise you might get into trouble. Again, in PopPK models, consider as separate covariates, not only the age, the maturation, and AKI stage, and for PPK models, as I already just discussed. Allometry versus BSA versus mechanistic clearance models. We're running quite a large project funded by the Bill and Melinda Gates Foundation project. If we can actually use existing compound models for PPK models, combined with the pediatric component of SimSip, and then not have to build our own compound model, and then pragmatically simulate dosing in kids for a lot of off-label drugs. So we were planning to do 60 drugs in 2 years, but where we really ran into is that many of the compound models and many of the existing PPK models have not been developed in a mechanistically way. So we cannot take these compound models and do this pragmatic modeling. And it's something that we didn't think, well, I think we did think about it, but we were a bit surprised that so many of the PPK models are not mechanistically. So also scaling of the other PK parameters that may be affected by renal failure, something that I think we should also think about, and use model drugs with similar PK properties as a surrogate. I think that's maybe one of the ways to go. And something that I also didn't discuss earlier today is I'm personally a strong believer that if we have so little data, also things like this IOX-SOL data or other data, the PPK models are getting really better, but then you also have to pay attention to all these aspects so that you really have a good mechanistic model, and then use the limited data to validate them instead of collecting all these PopPK data from so many patients. I think that's, well, maybe I shouldn't talk to you, but maybe I should talk to my academic colleagues, because we continue to do all these big PopPK studies and then say we don't have enough data. I think this is personally for me the way to go, because these studies are hard, and especially this population of renal failure patients is so small. I know many of you are using these PPK models, but this may add a step to it. And also consider combining the PopPK and the PPK model results. So I'd like to thank the Go workers and people contributed to all the work. And again, no child deserves bad medicines.
Thank you so much, Saskia. Our next speaker is Tom Nolan from the University of Pittsburgh.
Thank you. Thank you for the opportunity to be here. This is such an important workshop, and I'm delighted to be here. So I was asked to provide some comments, some brief comments regarding this topic. In the absence of an objective slide, this is my objective, and that's to try to comment on this issue of using BSA-indexed GFR values versus what we call individualized or de-indexed values. And there's a host of other terms that have been used, and one of the difficulties of this space is harmonizing language and terminology, frankly. So I'll do my best to comment on that and then to provide some commentary on the implications to pediatrics. Here's my disclosures. I'm an academic at the University of Pittsburgh, so I have consultancies, editorships, and I serve on advisory panels, and have been fortunate enough to get funding from NIH. All right, so this is a busy slide. Really, the purpose of this slide is to illustrate this idea that there's been a fascinating evolution of kidney function over the last 50 years. It's really impressive when you think about where we started from, and that's assuming you say we started from the mid-70s. We really started far earlier than that, but at least starting from the mid-70s with the publication of the Cockcroft-Gault equation, which very quickly became entrenched in clinical practice, through to the 90s and the evolution of the eGFR equations. There really has been a dramatic improvement in our ability to estimate kidney function. And what you see here on this table, which is from a very nice paper by Leslie Inker in New England Journal from just a couple of years ago, shows really the evolution of CKD-EPI. So these are just the CKD-EPI equations, and you see here that there are equations from 2009 which were based on serum creatinine, and it just simply lists the evolution down to the most recent 2021 version of the CKD-EPI equation, which removes the race term, and it shows that in both the serum creatinine as well as the combined serum creatinine and cystatin C version. And obviously, what this shows is the different coefficients that go into it and whether or not the race term has been included. Now, we can argue about the level of precision that each of these has, and we heard the term P30 earlier. I think the more important issue is to focus on some of the issues like body surface area and the use of body surface area and either the indexed or the de-indexed version of the equation for drug dosing. From a bedside standpoint, as a clinical pharmacologist who's looking at patients and has to use this information to understand how to dose drugs, frankly, the difference between some of these versions of the equations is far less than the differences that we'll see when we used individualized or not individualized eGFR values. And that's what I want to comment on and show you a little bit about today. And that's all to say the reason it's important is because of this idea of personalized medicine. This is everywhere now. We talk about personalized medicine, and I often say, well, guess what? One of the earliest ways to personalize drug doses was based upon an individual's kidney function, going back to the 1950s when aminoglycosides were first dosed on the basis of a priori knowledge of someone's kidney function. So it's very important to understand someone's kidney function from a drug dosing perspective, but we also need to understand that from a pharmacokinetic perspective, the renal drug clearance of a drug that's predominantly cleared by the kidney is proportional to an individual's GFR, not to a normalized or indexed GFR per se, and I'll show you how and why that is. So and it becomes interesting when we try to reverse engineer what are contemporary eGFR equations and the data that are automatically reported when we need to use creatinine drug dosing recommendations that are based upon creatinine clearance values. And this is still the vast majority of drug dosing recommendations based upon kidney function are based upon creatinine clearance. It's changing. The tide is beginning to turn as new drugs are being evaluated over the last 5 to 10 years. There's been a clearly an increase in the number of drugs that now have drug dosing recommendations based upon eGFR, either indexed or not. But nevertheless, as of today, the vast majority of drugs that are dosed at the bedside are dosed with creatinine clearance-based recommendations. So we need to know how to do that. One of the problems, which this study very nicely illustrates, is that when you use eGFR-based estimates and you try to reconcile them with Cockcroft-Gault or creatinine clearance-based estimates with different units, there's an incredible amount of discordance that you see. These are 3 drugs. First of all, this is a study done in about 120,000 patients receiving PCI. It's a retrospective analysis. So PCI patients after percutaneous coronary intervention are receiving either antiplatelet or anticoagulant drugs, which you see here. These are 3 commonly used drugs, and they have drug dosing cut points, 30, 50, and 60. So this is a very simple analysis where kidney function was estimated based upon these 3 equations. And what you see here is the concordance or discordance, depending on how you look at it, of the drug dosing recommendations, meaning did these 2 equations agree with a drug dosing recommendation on the basis of this recommendation being 30, for example, with bivalirudin. And what you see is that, as you would predict, the 2 eGFR equations, that this, MDRD versus CKD epi, agreed much better than when you compared one of the eGFR equations with creatinine clearance. Makes sense. I think it's fairly intuitive, and they're different units. If you're using indexed units, which they did for the eGFR values, for non-indexed drug dosing recommendations, it's going to lead to issues. Now, part of the problem is that we are not 1.73 meters squared, at least in the U.S. We all know that in the U.S. Our European counterparts may be less familiar with this idea, but in our country, we are not 1.73 meters squared on average, and in fact, we're growing larger by the day. And this paper from the New England Journal a few years ago nicely illustrates the projections, and that is that by 2030, about half of us are going to be at least on the upper end of overweight, meaning we have a BMI that's approaching 30, or will be moderate to, or have what's listed here as moderate obesity or higher. So we're large, we're greater, we're larger, we have a larger body surface area than 1.73 meters squared. And this impacts the assessment of kidney function on medication-related decisions. And that's nicely illustrated here, I think. This is adapted from a paper by Sylvia Titan and AJKD a couple of years ago. And all this very simple diagram illustrates is that if we use this as our benchmark, 1.73 meters squared, as we grow larger than 1.73 meters squared, the indexed value that is automatically reported, which is so often interchangeably used for creatinine clearance-based recommendations, as we are larger than 1.73, indexed values underestimate the de-indexed values, which are in mils per minute. This is very important. And on the other hand, if we are much smaller than 1.73 meters squared, which pediatrics would generally fit into, the indexed value, mils per minute per 1.73 meters squared, overestimates the individual's kidney function based upon mils per minute, which is the de-index value. So here's an example that we deal with. This is a typical individual, perhaps, who may be overweight in our country. What I've done here, this is simply to illustrate the case in point that we are dealing with every day at the bedside. This is a drug, Paxlovid. It's a combination product, which I'm sure most, or at least many of you are familiar with. It became quite popular over the last year. So this is an example, a 65-year-old man who's COVID positive, prescribed Paxlovid. He's got a serum creatinine of 1.6. Well, based upon a height of 5'10" and an actual weight of 250 pounds, and using the Mosteller equation to calculate BSA, his BSA is 2.37. So he's larger than 1.73 meters squared. Using the National Kidney Foundation GFR calculator online, which I'd recommend you all take a look at if you're not familiar with it. At least for adults, it's very nice. The indexed eGFR value for this person would be 48. That's mils per minute per 1.73 meters squared. But if you convert that to a de-indexed value in mils per minute, which I would argue is the appropriate term to use for drug dosing in this person, we achieve a value of 63. Well, is 63 the same as 48? It depends. And I would argue that for a drug like this, which has a drug dosing cut point of 60, perhaps now in somebody who's COVID positive, who's becoming quite ill, in whom this drug is indicated, perhaps we should be using a higher dose based upon what I would argue is the kidney function that is going to dictate clearance of the drug, rather than his index value, which would lead us to dose reduce the drug in this person. So this is a very common conundrum that we face at the bedside when we're using these automatically reported indexed values of GFR. The latest guidance, this has been alluded to already today, but the latest draft guidance from 2020, the pharmacokinetic guidance for determining drug dosing recommendations in patients with renal impairment, now incorporates some language specifying that use of consistent units is recommended when comparing these two estimates. So de-indexing eGFR to express it in mils per minute. So hopefully that will begin to translate to labels that will have one or at least both, if not de-indexed values alone. Some key considerations very quickly are the units of measurement, which I've alluded to. This is a very important issue. In my mind, it's more important than arguing about a couple of mils per minute difference by using one version of CKD epi versus the other, but nevertheless, that's also an important issue. When we are de-indexing, this is the manner that we do it. If we have a value that's automatically reported 1.73 meters squared, we just take a ratio of BSA to 173. And then size descriptors are always important. So ideally, we should be using the size descriptor when we calculate kidney function if it's reported in the label or as it's reported in the label. So what are the implications to pediatrics? This is where the rubber meets the road. So what? So how do we take this information? How do we translate it to pediatrics? Well, this is the ABACAS example that was presented earlier this morning. I find this fascinating. And one of the things I find fascinating is that, number one, which is a huge assumption, is that the assumption was made in doing the modeling that PK was proportional between adults and children. There's a lot behind that could be debated. And when you think about the incredible changes that occur from neonates to age 18, it's mind-boggling to me to think about the fact that we're just going to treat them virtually the same and say that there's proportional PK changes. I'm not sure that that's necessarily true. But then when we look at the drug dosing recommendations that were provided in the label between adults and pediatrics, it's interesting to me that the exact same categorical cut points were used. However, the adults are based in mils per minute while the pediatrics are indexed in 1.73 meters squared. Remembering this previous slide, when we're looking at pediatrics, and particularly, if we look at a 2-year-old, the body surface area is going to be so much lower than 1.73 meters squared that that's going to translate to what could arguably be a very dramatic difference in the clearance, even within one categorical breakpoint compared to the other, just simply because we're going to now adjust based upon body surface area. So the clearance will be much different. The patients may be, receiving a dose that might not be ideal given the indication of that drug. So implications, again, we should be looking at dosing recommendations in our patients. Typically, they're weight-based, as you all know better than I do in pediatrics. Given the evolving nature from neonates to age 18, I think that there's going to be dramatic, obviously, complexities that are going to be seen with respect to the relationships between all of these variables, between weight, BSA, and the clearance of those drugs. And we really should be individualizing rather than just lumping them all into greater than 2 or less than 2, I think. And then particularly in adults, as their kidney function matures, in my mind, a 17-year-old who's post-pubertal probably has adult-level maturation of their kidneys and could be receiving kidney function doses, but obviously more information is necessary to clarify that. Right on time, here's my summary slide. I think the biggest factor relevant to today is the last bullet, which is that clarity on translation of kidney function ranges that are based upon creatinine clearance in mils per minute, like we saw with the AYVAKAZ label. This is really important, and corresponding dosing recommendations to pediatrics need to be clarified. So I'll stop there. I'm right at time. Thank you.
Thank you so much, Tom. Actually, at this point, I would like to ask the panelists for the second session to come up. And at the same time, I'm going to ask Henrietta if she can come and just help us recap on the case that she presented on earlier. So again, if the panelists can come up, and we're going to start the discussion with the presentation of the case.
Alrighty. Good afternoon, everyone. So the same disclaimer as before applies for this talk. I'll essentially be providing a recap of the information that I presented this morning, and just highlighting some of the key bits of information pertaining to the ceftazidime-avibactam case example. Okay. So we took a brief look at the exposure matching framework that was used to support the approved dosage regimen in the general pediatric population, since this was the same approach that was used to inform dosage adjustments in pediatric patients with renal impairment. However, as we noted in the morning, in pediatric patients with renal impairment, there's a lack of sufficient PK data in order to be able to characterize the effect of renal impairment in that population. And so to circumvent that issue, the effect of renal impairment was extrapolated from adults. The working assumption underlying this was that the effect of renal impairment on PK would be proportional in adults and pediatric patients, specifically those 2 years of age and older, given that renal maturation is expected to be complete by that age. However, in order to move forward with using the adult data to simulate the expected exposures in pediatric patients with renal impairment, we first had to bridge the two different approaches used to estimate renal function in adults and peds. And this was achieved by showing that BSA normalized eGFR and normalized creatinine clearance were reasonably similar using the adult data set. Fortunately, don't have the plot illustrating this, but that was the basis for that. Okay. So from there, we can look at the simulated drug exposures, and beginning here with the avibactam exposures. So we looked at the for peds 2 years of age and older, avibactam exposures were simulated for these patients across various degrees of renal impairment. And so what we observed is that for pediatric patients with the estimated normalized creatinine clearance less than or equal to 50 mLs per minute, that ceftazidime that ceftazidime exposures exceeded the established safety threshold unless dosage adjustments were implemented. And then we had similar observations here for avibactam, again indicating the need for dosage adjustment when the normalized creatinine clearance exceeded, was less than 50 mLs per minute. Okay, so ultimately the information presented in the last two slides is what was used to inform the recommended dosage adjustments by renal function for pediatric patients older than or pediatric patients 2 years of age or older. Okay, so the last thing that I touched upon this morning was why we don't have any recommendations for use of ceftazidime avibactam in pediatric patients less than 2 years of age with renal impairment. The key thing here is that given the ongoing renal maturation in the subpopulation, we're unable to extrapolate the effects of renal impairment from adults, since again the assumption that the extrapolation used in peds older than 2 years of age was that renal maturation was complete. So that was the key difference there. And ultimately, given the lack of sufficient PK data to characterize renal impairment in this subcohort, we're unable to provide dosage recommendations in the setting of renal impairment. And that is the extent of my recap. Thank you.
Thank you so much, excuse me, Henrietta, for helping us recap the case example. So we're going to move to the panel discussion. I'm joined by my colleague Yoshi Fukuta from Lilly. And we're going to start off by taking clarifying questions from the in-person attendees or from those online.
Thank you. This question is for Saskia. You showed a couple of PBPK models, and in terms of those particular models, including the one that you published, for any that had data, how did the simulations differ from just assuming proportional, like what the dose would have been if you just assumed proportional differences in adults?
You know, that's a really good question. I don't think we looked at this. No, we didn't look at this. We just went onto this endeavor to see if we could predict what would happen with this PBPK model. No. So that's a good question. I'll take this one back to look at. I was actually thinking the same. I was actually coming up with the same question for myself. Because these were all the kids. It was HIV study. They were kids above 2.
One of the questions that I have is when translating data from adults to pediatrics is that ontogeny of the enzymes that are breaking down the drugs could have a profound impact, and that you may make completely different metabolites or the metabolite clearance. What would you recommend for the translation about looking not only at the PK data from the parent drug, but also on the metabolites?
Okay, so there are two aspects here. So one aspect, and I don't think that's indeed always appreciated, are the metabolically clear drugs with active metabolites. and when you have renal failure. And I think that adds a little bit of complexity to companies to give advice on what to do with renal failure in metabolically cleared drugs. And that's the interaction between the ontogeny of metabolism and the ontogeny of renal function. Irrespective of AKI, I think that's already quite complicated in very young kids. But again, we do have these data, but it is often overlooked. So I would indeed ask companies to also, and the regulator also to think about this. And the other thing is, indeed, you're one of the few people who have published on this, is the different metabolites that can be formed in kids. Well-known example is, of course, paracetamol, which is mainly has mainly sulfate metabolites, and then when you grow older, the metabolites it turns into glucuronides, and that's not a big issue with renal failure. But you also showed for sirolimus that there's a metabolite that you don't see in adults that you see in very young kids. And then again, if these are active metabolites that are renally cleared, that adds a complexity to it. But that's, then we make it even more complicated. But it has indeed not been mentioned before. The issue of maturation and renal failure with active metabolites.
Thank you.
Can I just add a comment to that? It's okay. I think there's a lot of uncertainty with it, but it's not completely a black box. And I think over time, and I think you had a slide in your morning talk where you actually highlighted the ontogeny of the different drug enzymes, which Dr. Kearns had published, I think, a few years ago, which actually details how the expression levels of these enzymes mature over time. And that maturation is now actually in use in what we actually call PBPK models. Is it absolutely perfect? I don't think it is, because we are contending with biological variability and everything like that. But we know more about it than we did before. And that premise is how we actually make our initial dose predictions going from adults to children. Mm-hmm. And mostly from a drug development perspective, not a pure clinical research perspective, these things are usually done in a sequential manner. So we tend to progress from adults to adolescents to the younger children and so on. So there's an accumulation of data that takes place that is corroborating what our initial findings are going to be. So by the time we actually come down to the very young, the infants and the babies, we are starting to hone on what we really don't know. So it's not completely a black box, and I mention this because I think it's important in this context that there is accumulated data over time now. Thanks.
Saskia, did you?
I agree with you, but I don't think that was Guido's concern. Guido's concern was more about the clearance of the metabolites. So we do indeed know a lot about the ontogeny of the drug metabolizing enzymes, but then we forget to look at the active metabolites that are then next renally cleared, and that's something that we also need to take into account looking at this discussion. But of course, we can learn something from the AKI data in the adults and then extrapolate that to the neonates.
But we do measure metabolites in clinical trials as well, if they're active. So,
yeah.
So I'll just add to that. I think it's more than that, though, Saskia and Guido. It was presented earlier. Martina presented earlier the pharmacokinetic. The recommendations for assessing pharmacokinetics in renal impairment, with the idea that there's two different designs. There's a full design for drugs that are predominantly renally cleared, and then for non-renally cleared drugs, there's a reduced design, with the idea that we use the worst-case scenario to determine whether there's a signal for changes in drug exposure, and if there is, then there's a full design that's recommended. So I think this adds a layer of complexity on today's workshop, because we're not just talking about predominantly renally clear drugs and proportional changes, but now we're talking about drugs for which there's not only changes in kidney function in infants, for example, but there are changes because of ontogeny with the metabolism and the metabolic or perhaps metabolic and transport pathways that are involved in their disposition. So in my mind, this is another workshop.
Yeah. So I'm glad you spoke up, Tom, because our first question was going to be, in what age groups can we assume similar proportional effects of renal impairment on PK? And that was clearly an assumption that was made in the ceftazidime avibactam, and you seem to share concerns with that assumption. So could you expand on that? And we would like to hear reactions, at least in the 2 years and older, and then maybe later we can get into the lower age group.
Yeah, my comment really gets to the idea that even if we agree that at age 18 months, I think it was mentioned earlier, or 2 years, that there's full maturation of kidney function, I think we also would all agree that from 2 years old to 18 years old, there's a tremendous change in body habitus, probably underlying organ function, probably other physiological pathways, all of which dictate drug disposition. So sure, kidney function and renal clearance of predominantly renally clear drugs may be less impacted if we're looking in isolation at glomerular filtration or filtration clearance. But there are very few drugs outside of our GFR markers like iothalamate or iohexol that are predominantly or exclusively filtered. The fact of the matter is that most drugs have at least some tubular secretion or some metabolic clearance or biliary clearance. So when you start taking into account all of the pathways that dictate drug disposition, I don't have data to present this, but it's my feeling, it's my suspicion that these things change and evolve over age. That was my. I don't know where she went.
Yeah.
That was my. That was my. What my comment was related to.
Yeah, wonderful comment. Yeah, Lin-Yao, do you want to talk something?
Yeah, I did want to comment on that. So, Tom, I think you're right that, of course, there are numerous variables that we consider in the ADME just to get the PK of a drug in a pediatric patient relative to an adult. But I think over the last 20 years, we've gained a tremendous amount of experience and knowledge, which we didn't have 20 years ago, about the PK of drug in children relative to adults. And so we have, I think, advanced the leveraging of that information through review of exposure response data in numerous types, mechanism of actions, classes of drugs, indications, where we've seen similar exposure response. And I think that gets at the very question you have, is how can you make that assumption? And so for a lot of classes of drugs now, particularly in anti-infectives, where we have a high degree of confidence that the diseases are similar and that the drugs that we're looking at will have a similar response, that is either through exposure response or through what we know about the class, that we have determined in certain cases that all we need to really do is match, the PK to get the right dose. And I think what was going on here in the renal impairment is that we had some confidence that, in fact, exposures were similar. We were able to rely on that for efficacy. And so in the situation of renal impairment, there wasn't much different in terms of what we would expect in terms of exposure response in the patients in whom the that kidney function was mature. So that's the 2 years and above. So I think there was kind of a two-stage extrapolation there. I do take fully that we have to be careful in that, but I think it was based on a lot of knowledge of the class of anti-infectives we were talking about. Now, that's that whole premise of pediatric extrapolation for efficacy, and you are hearing a little bit that there's kind of some extrapolation here for safety too, which we've recently described in this international guideline that we put out on pediatric extrapolation. So I just wanted to respond to that because I think it wasn't that we necessarily had the data in renal impairment in pediatric patients, to support. But there was this confidence based on what we already knew about this class of drugs between children and adults and even on the efficacy side. I hope that helps.
I think it does, but it sure sounds in some ways that it's class-specific. I wonder if we move out of the anti-infective space, is that a model that could be used?
If I could respond to that, too. So that question's right on, right? Because in the places where we have less confidence that the exposure response is going to be the same, then taking that to the next step, which is what about in renal impairment, then we would have the same, lack of confidence potentially. And we want maybe more PK data in that pediatric population, for sure.
So if we were to accept that the exposure-response relationship for efficacy and safety is the same in adults and pediatric patients, including in patients with renal impairment, the question we have, if you're looking at the slide in front of you and the dosing table that's in front of you, let's assume that this is eGFR instead of estimated creatinine clearance, just for the sake of this exercise. Greater than 50, it's 2 grams. 31 to 50, it's 1 gram, so it's a 50% reduction in dose. Our question to you is, down to 2 years of age, can we assume this proportional reduction in dose can be translated from adults to peds? So for the different cutoffs, can this percent reduction or proportional decrease in dose be translated to all pediatric patients with mature renal function? And if not, why not? And if yes, why? Sure. Can we advance the slides forward, please? I'm unable to do that from here. And one more. Further. So, one more. One more. More. There you go. Go ahead, Lynn.
I mean, maybe I'm not supposed to answer this, but I'll answer it anyway. I think it has everything to do with the confidence you have that the exposure responses are similar on the efficacy side, and that there isn't something about the safety or the metabolism of the drug relative to, mature kidney function that would preclude you from approaching it this way. I think under 2, as Saskia nicely described, that's a different ballgame. And I think for diseases in which we don't have the same confidence, it's also different. That we're going to have, data to support that, the changes in renal function do end up giving similar exposures and therefore translate to a different dose.
I would just advocate, this looks like a simple system in that it's really not metabolized very much. And it might be easier to proportionally reduce. But when you have and you don't have a reason to assume metabolism would be active in less than 2 years of age. So you might get away with it here. I think it gets much more complicated when you're dealing with drugs that 60% of the medication is metabolized.
Thank you. Saskia, and then Jeff Barrett.
Sorry, my jet lag just emptied my brain. I'll be back.
I'll jump in here while you're filling up. I just wanted to make the point when we talk about things like proportional and normalize, we're typically talking about a linear transformation, simple division. And it's not clear for all drug that this is generalizable and that linear is appropriate. So, and the other thing, kind of as a point of reference here, occasionally what we're normalizing by is a parameter that's already adjusted for things like race and gender. So you could be double accounting for things depending on how you've normalized or actually fit the model. So it's just a cautionary tale. I worry about seeing so many cut points where this kind of linear transformation, it may be okay within cut points, but across several of them, it may be more problematic.
So maybe I can probe Dr. Schwartz and Jeff a little bit more. Given the limitations of collecting data in pediatric patients with renal impairment, and most of the time we would have to work with data in adults, how can we best leverage the data that we have in adults, again, to pediatric patients with mature renal function, both for drugs that are predominantly renally eliminated, but also for drugs that have a component of hepatic metabolism? How does that get translated into dose adjustments? And it looks like Saskia wants to help you out.
Yeah, the brain is back. Well, as I showed you in this morning, so we just reviewed, there's quite a number of POP-PK papers where people have looked at the impact of AKI. I think if you leverage all those data, systematic review, and really dig into this data, I think that could provide an answer to this. Do these data that are already out there, do they actually support this 2-time or this proportional and this proportional decrease that's similar to what you would do in adults? I think but that takes a bit of time from someone or more people and some smart modeling people to figure this out. But I think that kind of data could be used already. And similarly, going down to newborns and preterms. And this is a comment I really want to make. When I'm on call in 2 in the morning, and have a patient that doesn't pee, you guys don't help me. Because and I agree, and I can understand that you don't put a dose advice for kids without renal impairment because you don't have the data. But I don't have these data in 2 in the morning neither. So we need, and this also called to the FDA, to the regulator, we need your best guess how to dose the kids less than 2 years old. Of course, that's why we have this meeting here, even if the data are very limited. Because now at 2 in the morning we have to come with something up which may be worse than if we would all use our brains and come up with something smart despite the data.
Dr. Schwartz?
2 things. One, the estimates that come through whatever pediatric equations are being used are not race-based, so there is no specific for that. The second thing is that, and we talked about this in intermission, an eGFR of 50, in a 6-month-old is, although it's normal, it's less than an adult, and the concept is just not clear. It's normal kidney function, and yet it may be too much of a dose. I think only, especially with metabolized drugs, it's going to require serial monitoring of both the plasma and urine levels. There's no shortcut here.
Well, I worked on, this type of simulations many years, and then we often use, index value to compare to adult, the value equivalent. So that is a way. And then, the beyond that should be, individualized, the dosing should be better for sure. But we need to have some, the indicators to see, consider already and then take into account that, the body size to compare that, functions. Then now, we can kind of, to see the same numbers to describe that, the how much, functions are there. So that is the way, that we can compare to adult information. Again, I think that Tom Nolan, he mentioned pretty nicely about, I think individualized dosing. However, how we can get that, the level. I think that we started from, phase 1 studies in the healthy adult to get, the PK profile. Started from here. Then, they go down to, the more information. Then, finally we can give, individualized dosing. For example, obesity. Without any standard, typical value for adult, how we can, individualize. Something like that. I think, that's depend on where we are, starting from, as a foundations. That's my understanding.
Thank you so much, Yoshi. Go ahead, Jeff.
Just another comment. I think you have a disparity of data. You have a boatload of adult data and an adult standard of care with a lot of these agents. So it's, if you're building a decision support system to guide a hospital, there's different approaches you may take as opposed to using a formulary-based recommendation from that standpoint. But again, I come back to Saskia, it's 2 a.m. and your child's not peeing. What guidance do you want? I think what you also need to recognize is that the disease progression in adults is very different. This is not a comparison for extrapolation on mechanism of action of 2 different agents, but how they get to an impaired state is very different between pediatrics and adults. So that is somehow embedded into this, cut point issue as well. And I think leveraging the adult data to its full extent may be a little bit misleading in that you're not really assessing how the children got there from that standpoint. And the mechanism by which you might make adjustments is different potentially. We don't have enough data. I think that's where we're finding ourselves in all of these questions, but that doesn't mean we can't get more of it.
And then,
if I could, to highlight, I think, George's point, and maybe to some degree Jeff's point too. If we look at the chart that's on the screen, let's say the average 3-month-old has a GFR of 30. Let's just, for purposes of argument, that their GFR is 30 ml per minute per 1.73 meters squared. Now it says here, 3 to 6 months of age, if you're normal and you have no renal impairment, your dose is 40 per kilo. But if you have a GFR of 16 to 30, which I just said was what we thought the normal would be, the dose is 18.75. So there you have a very clear, issue about, do you take the actual GFR, do you take the percentage of the, of what normal would be as the impairment to say this is the dose. And again, I've been trying very hard in my head to understand why we would use anything but the actual clearance number, because that's how much is getting filtered per minute at the glomerulus. So if it's only 30, then it's only 30. It's not, doesn't matter that it's normal for a 3-month-old, right? So I think this is a very clear example of, how should we be thinking about providing this as estimates, whether it should be scaled to what it was for adults and the percentage decrease versus what is the actual GFR in a pediatric patient.
I think for those online.
Thank you. So to Lynn's point, I think the difficulty here is even for children with mature renal function, 2 years and older, GFR, say 100, indexed to 1.73 meters squared. As you move towards that 2-year-old age range and you try to individualize the GFR, you get to a very low number as their body surface areas go down to 0.8, 0.7, 0.6. And before you know it, you are at an indexed, non-indexed GFR of 30, 40, 50 for a 2-year-old who's supposed to have mature renal function. And how do we address that in dosing? Because as you can see, not to be glib, we've basically added on the 1.73 meters squared to what's from the adult table. Is that appropriate to do? Is it only appropriate to do in an adolescent who's adult size? Is it still appropriate to do as you move down the body surface area, normal values as the size of the child goes down towards 2 years of age? I think that's an important question.
And I think what would be helpful to hear is how much uncertainty are we willing to accept, right? This was data that was accumulated across 3 different programs, hundreds of patients, and we were only able to get a couple patients with moderate renal insufficiency. So the ability to generate clinical trial data is very limited. And to Saskia's point, clinicians want some guidance. So again, the question is down to 2. Yes, there are uncertainties, but at least for drugs that are predominantly renally excreted, can we say, with some uncertainty, but can we reasonably extrapolate the proportional effect of renal impairment on dosing. And again, it would not be the same dose, it's just the proportional impact of renal impairment on PK, down to 2, and then maybe down below 2 years or below 1 year of age, we can have additional discussion. But it's really important to get maybe not a consensus, but some really strong recommendation in this space, given the limited number of products that have labeling information, even down to 2 currently.
My comment about that is that if you're able to do that dose proportionality and you're assuming there's a similar exposure response relationship in pediatrics and adults, you're also when we talk about exposure, we're all talking about what's in the blood, which may not actually be the site, the target site or the site of infection. So you're also assuming that the blood to whatever target organ permeability, penetration barrier is the same, which we know is not true because especially in that neonatal period, when you think about the blood-brain barrier, it's still being developed. And I think to Saskia's point that we need to really be thinking about PBPK because where you can think more about how are the transporters between the blood and the brain being developed or between the blood and the organ. So I think it's a really complicated question because we see toxicities in adults that don't exist in young kids, and then we see toxicity in neonates that we see in that we don't see in adults just because of the permeability and penetration issue as well.
So could I make a comment that may help with the comment that you're making? So we will characterize PK in all the relevant pediatric age groups who have normal renal function, right? That's standard as part of drug development. So this is with the assumption that we have that data in patients with, whatever is considered normal renal function for that age group. So the question is then how do we bridge it to pediatric patients with renal impairment? So this is really just to match exposures, assuming exposure response is similar. How do we derive a dose that will achieve similar drug exposures as those pediatric patients with normal renal function?
Right. I guess what I'm saying is that when we use the word exposure, we're often talking about what's in the blood, but
Correct.
Not necessarily the site of action, which we also have to think about. There's also a developmental aspect there because if, let's say, the drug is targeting the brain, the blood-brain barrier is very different in a neonate than it is in an adult. And so should we be able to just translate the exposure in the blood in an adult? Should it be the same exposure in blood in a neonate, regardless whether there is a renal impairment or not? So I was just saying that there's an additional assumption when you try to extrapolate exposure.
Just to respond quickly to that, it depends on the indication, right? So we would certainly have more concerns if the drug was intended to treat meningitis. Here, we've already established, the effective exposure in an adult and the exposure, the dose that would be used based on exposure matching in the pediatric patient. So that part of the efficacy story, I think we're pretty confident about. We've done that in anti-infectives for many of these, and for all of these indications, CUTI, CIAI, HAP, and VAP. I take your point.
And it is the same assumption that we work under in adult development programs. So in adults with renal impairment, you're trying to match the exposures that have been found to be safe and efficacious in patients with normal renal function. So
but can I just say that we make that assumption, but you're getting the adult data. You're seeing, because, how many above 60-year-olds have renal impairment, so it's easy to confirm that relationship or confirm that assumption by getting the data in the adult renal impairment population. And I agree, Lily, that it's hard to collect the data as we've shown here, that it took, we didn't have very many patients with renal impairment. But I do think that it's worth a conversation maybe with industry, right? I mean, are we really focusing on that population? How hard is it to collect? Because there are a lot of, the nephrology community here can tell you loads and loads of patients in their clinics who have renal impairment. And if they were going to expose to AbbVie, to this drug, we'd have the data. So.
Thank you. I think, Martina, you wanted to comment?
I just had one question on the tissue distribution because we would usually have data in pediatric patients with normal kidney function. So unless we thought that renal impairment would affect sort of tissue distribution beyond sort of what you're saying, the ontological things, I think that would then just add sort of like other layers of complication that we may not be able to answer just yet. So the question is it can we find that out, or is it possible to model some of this at this stage to provide at least some data in the label? Yeah, I also just forgot the follow-on question that I had, and I'm not jet-lagged, sorry.
Oh, Guido.
I would like to expand the discussion on where we perhaps have the least knowledge, and that's when patients are on renal replacement therapy. And especially, we have some data on hemodialysis, we have less data on peritoneal dialysis. We are quite empty on CRRT. And I was just wondering what the panel would think about using adult data, translating that to children, especially when I'm thinking about the ICU, and we have no idea how much norepi we are removing. We have no idea what really happens with CRT, and the diversity of methods is much greater in pediatrics than it's in adults. So I wonder what you think, how much could we use those adult data, PK/PD modeling, to get to answers?
One of the things that we've done in adults is begin to try to better understand the use of something called effluent flow rate when we are using CRRT in our patients for the purposes of not only dosing the actual renal replacement therapy, but together with some of my colleagues from FDA, a number of years ago, we published a KHI paper, which is a partnership between ASN and FDA, to begin to think about that very issue, Guido, not just in peds, but in adults and peds as well. And one of the biggest issues that we struggle with is the idea that there's so many different modalities that are used, and it changes from Vancouver or Canada to Pittsburgh to Boston and to Europe, right? It's different in every center. So how do we take that into consideration in understanding how we should dose drugs? And the easy answer, I think, is effluent flow rate, because it's agnostic to modality. It's directly related to the clearance of at least small solutes that are readily cleared by dialysis modalities. So I think the way to progress in this area is beginning with understanding what is the effluent flow rate and how does that, what's the relationship between effluent flow rate and the clearance of the drug in our patients. And so as long as we can characterize effluent flow rate in your patients, I think that we can begin to do that. Method of what? Of renal replacement?
The method matters. When you have high flux dialysis, then you remove in one session 40% of the vancomycin, right? And you have to redose it after the second treatment. The filter characteristics influence, especially on CRRT, what the clearance is. Also, what matters is the albumin level, right, and the amount of bound drugs, etc. I have really conceptual problems to how to model this, and then so of course you could measure the combined clearance. You could measure cystatin C and see this sort of the HbA1c of the residual kidney function, but it's only for small molecules, right? And it's not, and the pore size of the filters vary so much that you could get even large molecules out with convective clearance, right? So how do we conceptually approach that?
Well, to be sure, there's more than one factor that dictates extracorporeal clearance of drugs. Certainly, from filter to filter, given the characteristics, the surface area, the membrane composition, the pore size, et cetera. There are many factors that independently affect the clearance of the drug. I simply am suggesting as a starting point, a way to normalize it, a way to take into consideration that we can, there's a common thread that can be used to begin to eliminate this idea that we can't compare between centers because we use different modalities. I think a starting point is to understand and to use the effluent flow rate.
And go ahead, Dr. Schwartz.
I'd like to say we could collect the amount of dialyzed material. You can do that quantitatively with CRT, hemo, and even peritoneal dialysis. And it would be a lot of work, but you could pool everything or get averages over time, and you could get an idea of the percentage that's cleared by that.
Just to bring it back kind of to the question that we're grappling with, and to your point, Guido, is that if we can't figure out like a way to estimate or assume or to model a dose in patients who have stable renal impairment, we're never going to figure out how to do it in renal replacement therapies. And I think when you can't model it, then the requirement will be to collect the data, whether it's through collection of the effluent, or whether it's a collection of data in the dialysate and residual renal function. I mean, all those. I'm getting hives thinking about this because it's been a while for me. But all I'm saying is that there's no replacement for data collection in that case. But I think the question that we're really struggling with, that we'd like to have better understanding, are what are the guardrails for, when we can leverage adult data, and is there ever a time, is this, like in the simplest case, are we missing certain issues? And if there are guardrails and we can't, even in the simplest cases, assume, then what kind of data are we going to need to collect to support coming up with a dose that could be used in children with renal impairment?
Martina, you look like... Okay. Vikram?
Maybe just a comment, and not to get into the details of this slide, which is clearly, or this particular submission, which is a focal point. But in principle, I think the way this has been approached is actually very practical and reasonable. Yeah. And I think we can obviously debate the exactness of each measurement and every detail, but in terms of providing a practical guidance based on some very simple assumptions, which generally hold true, this is a very, very reasonable approach. And in this case, AbbVie, or whoever the sponsor is, I think it's AbbVie, didn't actually go all the way down. I mean, they stopped at 2. But theoretically, the same principle actually applies. And so back to the question of if a prescriber is really looking for some practical guidance in lieu of actually observed clinical data, this is really a practical approach to do it. Because what's the option? The other option is actually really embarking on collecting clinical data, which they actually did here, but it's very few numbers. It's like 1 or 2 subjects, I think. Is a long drawn attempt to get that data. And the question is, do you stop any opportunity for these children to get treatment while you wait for all these things to mature? In lieu of that, this is, very simplistically, without the details, really the best one can do. And I think to Dr. Schwartz's point, this is really a wonderful case because the fraction excreted unchanged is, what is it, close to 80 or 90%, I think, in this case. And so it's a exemplar of that situation, perhaps. So now if you start dialing back into situations which are, say, 60% or 30%, you can actually envision where we are going to start falling off in terms of making these predictions happen. And at the end of the day, just very practically speaking, it comes down to the therapeutic window of the drug and what we are actually willing to accept in terms of differences between these recommendations. So, you're going from 50 to 25, and the next is 18.75. So how much more can you splice this? 16.75, 13.75. There's going to be variability in drug concentrations. So these are the practical things, I think, that really come into play here. And so if you're looking for something to anchor our thinking and say, if we really needed this information, this is a reasonable approach. And then we can discuss the details of, okay, down the road, how do you get additional data or not? What is the need for it? How do you maximize your data collection in your pediatric program, which is heavily weighted towards children with normal renal impairment? So can we collect enough data there that allows us to make these inferences? And I think that's where I would be thinking about this.
If I could build on Vikram's, and it's a question to you, Dr. Schwartz, and others on the panel as well. So looking at the table that's provided to us, let's assume the last two categories were combined. So it's less than 15. The dosing recommendation was 18.75 every 48 hours or every 24 hours. If we do what Vikram suggested, if we were to extend this down to birth, in a neonate that has a baseline eGFR of 15, any change in renal function, the patient would still end up getting the same dose. Is that reasonable? What would be considered a significant decline in renal function that would warrant a dose reduction or an extension of the dosing interval in young infants?
I don't think that we could. When you're down to 15, it's going to be very hard to see small changes, even moderate changes in that function. But I think there's no substitute for measurement. The one thing that I wanted to bring out to everyone is that the 6-month-old or the 3-month-old is going to have a much higher total body water, much more aqueous space in which to dissolve these meds. So it's not exactly the same as even a 6-year-old or a 2-year-old because we're up almost 70% water there. And so those drugs might perfuse a little, they might get diluted actually because the dose is not appropriate. And we don't want to underdose a sick baby. So it's a good place to start, but we might have to think, well, okay, I'm going to give an extra 10% because of the volume differences. There could be some logic there because there's pretty good data on total body water spaces in babies and versus Fries Hansen has published on that years ago.
Go ahead, ma'am.
So just to make sure I understand what I'm hearing, that the circumstances in which we might be comfortable leveraging the data from adults, and I'm going to leave off the table right now how much confirmatory PK we might need, or that, look, as close to fully renally, cleared as possible without additional active metabolites. So this is the case here, that above 2 seems less risky than below 2 because of the whole issue of organ maturation and the transporters and the CYP enzymes, et cetera. That the therapeutic window of the drug, that if there's a wider therapeutic window, then that gives us confidence. It sounds like outside of those, that's what describes this scenario, and things outside of that scenario, it sounds like we get less confident and maybe will require data to confirm. Is that what I'm hearing?
Just make one clarification. When I brought up the therapeutic window, I didn't mean to say that just because it's a wider therapeutic index, therefore I believe the prediction more. That was not my intent. My intent was actually to say that I think that's one factor in actually assessing the weight of the prediction and how we should be thinking about it.
My concern then with saying that the age group where we have the most uncertainty will be the age group where we will need more data, is those are the age groups where we already have difficulties collecting data. So
I have to push back on that, and this is what we do every day at FDA. We have these conversations. So it's not like, Lily's, a good friend of mine, but we haven't, this is a new field. We haven't really tried. I mean, when have we actually even asked for this in a really coordinated or, rigorous way? Mm-hmm. So I don't know. I recognize if we extrapolate the data in collecting, clinical efficacy data less than 2 years, right, and in the neonates, then yes, the answer will be that it will be difficult, right? But I don't know how difficult yet until we try.
Saskia?
Well, I think it will be easier when patients with AKI can be included in ICU studies. I think the exclusion criteria in these patients there are so many that it's very hard to include these patients in ICU studies. So if we can include AKI patients or patients with, and this hasn't been mentioned today, augmented renal clearance where there's no dose advice for kids who have GFRs of 150 or even up to 200. That's a different story, but again, I think it will be easier. And as the physician, I also like to push back that we do need these data. But again, if the result of this 1.5 day will be that you can, with a renally clear drug like this, you can extrapolate and you don't need clinical data, then again, I would push back on this because that's the assumption we now made. And it would be very helpful if we have data. And again, you don't need many patients. Even if you would make a PBPK model and you can put these few patients that you have in there and you can confirm this, and not one study, but one drug, but all the companies have to do a little bit of this. In the end, the FDA can get these data and show that it indeed works. And I think that could be a transition phase to in 5 years that you can say, yes, we can extrapolate. But I'm not in your shoes, so maybe my talk is too easy.
Maybe, Vikram, you can chime in from the industry perspective.
I don't know that I can speak for the industry, but I think Dr. Webb actually made a wonderful talk this morning where he very practically listed the challenges I think we face with doing these studies. So I don't think there's an intent not to do these studies, but there are really, really practical challenges in doing so. And maybe every company's had this experience of how difficult it is to enroll children, especially in that age group. It's not easy, and we have personal experiences. And then when you add a layer of bringing in patients with renal impairment, that's even more difficult. This company actually has tried to do it, and actually it ended up with, I forget that, 1-2 in the moderate group. So, here we've got some learning. If we actually looked at their predictions to the observed data, that's actually going to tell us how well this extrapolation is actually done. But it's not easy, and I think my plea would be that we are very, very thoughtful about when and how we are requesting this additional data, and only be doing it when there is really a use case and a need that justifies this data to be there. Else, I think it's not going to be easy, and it will, it'll get in the way of, our bigger goals of actually getting access to children.
I'm just wondering, is there anything that, for example, even if that information might not be sort of requestable in a quote unquote sort of pediatric renal impairment type of sort of setting, but it could be some of that data could be obtained from the clinical setting. So is there any sort of plans or anything, or what is the potential to maybe use I don't know, scavenged samples or something like that, to when these drugs are used in these patients to potentially, I see a hand up there, to potentially then sort of, quote unquote, close those labeling gaps sort of subsequently to maybe approval, but to think about this prospectively before or during drug development.
If I can comment, Jan Mark from Boehringer Ingelheim. So this will be also part of my presentation tomorrow, because I think there are two crucial questions, and one is, what do we exactly mean with data? What data do we need, and when do we need the data? Because we have examples where we have pediatric labels, where we feel confident that we have sufficient data for a label, but at the same time, we also acknowledge that there are uncertainties, and this is why we do further data collection in a post-marketing setting. And this can be, in many situations, much easier compared to a clinical trial setting. So therefore, for me, it's really how we design or how we ask the questions what data we need, and then how we design the clinical development plans and evidence generation plans, and that we are really also open to constructs where we do not have to collect everything in a clinical study, and where we have the opportunity to clearly define what we need, but then do it in a more post-marketing setting. That is oftentimes much easier from a data evidence generation perspective.
Just to further what he said, I think we need to make use of our new pediatric clinical trial networks, C4C in Europe, IACT here, to actually carry out some of these post-marketing studies where they can actually, I mean, the hard part is finding the patients who get these drugs after they're approved, and then getting it systematically, getting the sites to actually, get those samples so that we can do these kinds of studies.
That's a really good point. Dr. Schwartz and then Martina?
At least for some of these drugs, we can sort of foresee that they might actually be used in the post-marketing setting. So, so there is a question sort of in which drugs do you really actively intend to front load this so that you have more information at the time of approval versus for which drugs might that not be so easy, because even if you open the enrollment potentially down to certain levels of renal impairment or kidney function, we've seen today that at least for some diseases it might be sometimes actually looking for a needle in a haystack. Maybe not for the AKI situations where anti-infectives and sort of other drug classes are used. So there you could think about when to front load this versus to sort of potentially post load this.
As a pediatrician, I can't tell you how many times I've used drugs off-label because so many of them are not on-label. And I mean, there's a potential resource for you out there, industry. The thing is that one has to at least realize there's a great drug like this around and that we would try it, and now we have to deal with it on a kid whose GFR is reduced. But partnership maybe with industry is really what we have to think about here to try to help everybody out so that these drugs can help the most people.
And with that spirit, in the context of developing a protocol, how would we inform the initial dose selection in these patients in the under 2 with renal impairment, given the constraint of a protocol versus the ability to adjust dosing in clinical practice? I'm just wondering if Jan or others want to comment. I'm sorry?
Probably in a PBPK-based approach, you take all the data in hand and make an assumption on what should be the dose. That should be the starting point for these kind of trials.
Mm-hmm.
Yeah, and here the question is whether a trial is needed, because if you have a model The question is, what do you need for validation? And can you do the validation in a post-marketing setting and wait exactly then for these rare patients and build a network to ensure that the right centers are aware where to collect the data? And this would be, for me, as a trialist, the question, what data do we need in how many patients or from how many patients? And this is where we would need our ClinPharm colleagues and modeling colleagues to tell us what they exactly need in order to then design the right data collection systems.
Len and Saskia?
I will just be just to clarify what I had meant to say as far as the need to collect data. I was not implying that it had to be pre-marketing. I was not implying that. But that there is a need to collect the data, and what type of data and when to do it, to Jan's very point. I think we'll hear more about that tomorrow, but that's an open question, and I think that we can talk about that. But I wasn't, my intent was not to say, well, you have to have controlled data and, 15 neonates, to confirm a model before you approve the drug, right? Because our starting point right now, as Shamir, very clearly said this morning, is that we put renal impairment data and dosing in adults, and there is nothing for children. So our starting point is that there's nothing. Mm-hmm. So whether we do it pre or post-approval, we need to start collecting something.
Mm-hmm. Point, Len. Saskia?
Maybe this is a bit too simple, but the huge interplay between the age and the renal failure will eventually result in an absolute GFR in mils per minute. So for the adults, for this drug, you have mil per minute dosing recommendations. So for the younger ones, can you not do this or come up with a dose, a priori dose where you do an estimation and then say measure GFR and then adjust the dose based on GFR and then collect the data? I mean, in the context of a trial, then of course you don't take into account the renal transporter and the differences in how they, and maybe the contribution of drug metabolism versus the renal clearance that may be different in the young ones versus older patients, like for example for caffeine. But at least it's a starting point. And then you get rid of, and then you have a certain GFR, absolute GFR, and you say, well, this was a normal GFR for age, or this was a non-normal GFR, and now I have my AKI data. So would that be an idea? And for those of you who haven't heard about it, caffeine is the example. Caffeine, and I think that's also important to mention as a side. This is a side note, but I think you should be aware. Caffeine is completely metabolized in us, adults. And there is a genetic polymorphism. When I did my PhD, I thought, oh, that's super cool. I'm going to look at the genetic polymorphism of caffeine in preterms who get it for apnea of prematurity. And I started to dig in the data. It doesn't make sense at all because caffeine is completely renally cleared in preterms. So that's another thing why going down extrapolation may get you into trouble, and that's why I really think we do need data, because the whole disposition may change. And I didn't mention that in my talk this morning, but just a side note why it's not that simple either. But you can come up with some ideas.
Len?
So Saskia, you reminded me of a really important point. So we had spent, just for the sake of the audience, we had spent in our planning committees talking about like, okay, so you get the data on renal impairment and you figure out a dose, but really, can you use it in a pediatric patient who has AKI? Because, this is all supposed to be for patients who have stable GFR or whatever it is. But as I'm hearing Saskia talk, can we look at the reverse, which is, okay, let's table the issue about whether or not these dosing recommendations are okay for AKI in kids. But can we take the AKI population to use to collect the information we need on clearance in settings of renal impairment? Because if we can use that AKI population, that's what I'd like to ask, the rest of the nephrologists here and the clinical pharmacologists. If we can, there's a much wider, it's still limited fare, but, there are a lot more kids who have AKI in addition to our kids who have CKD that we could use to collect that information. So I'd like to hear what folks think about that.
Go ahead, Dr. Schwartz, and then Guido.
Go ahead.
I don't have a perfect answer, but I think the willingness of participation in a study in an AKI patient in the ICU will be much greater than in the CKD population, especially as they're already in the hospital, especially they could have access to the studies, versus a CKD patient might only come 3 times a year into the clinic, and when the study protocol requires more, it will be a challenge. I think that that's actually a really good model because of the willingness, of the accessibility of data. Many of them have an outline, so you could draw some extra blood, and we could collect at the same time actually the effluent from the dialysate, and we could collect the urine if there's any residual left, so that we can get a more complete picture. And one could collect at the same time the entire group of medications, so that you could also study drug interactions, because that's another big unknown, in my opinion. The challenge amongst pediatric nephrologists is that of all the pediatrics has the lowest number of studies, and of all the pediatric subspecialties, pediatric nephrology is at the very bottom. And it has to do with culture, has to do with inexperience of participating in trials. But the biggest hurdle is lack of sponsors, right? So we need somebody like the NIH and FDA or so to support these things, and with the objective of improving the safety. But I think it's a lovely idea, and it's an idea that's doable. And you could have even just 8 or 10 bigger centers with a high volumes. And the only advice I would give is that you want to have a very, very heterogeneous population, and you may want to consider this in well-resourced and less resourced countries. So even though the less resourced country may still do CRT or may have the carpe diem that we don't have, etc. But I think this is a great idea.
Guido, I think I have one comment about it. You know, that when I was in the academia, we had a lot of questions, like you were starting the study, what dose, we can start with as a clinical pharmacologist. And I always, need to look into the details, what data is there available, and then how we can start from. Of course, at the end of the day, we have to discuss about the risk benefit and then the safety concerns about it, how much, concentration can be go above, what we have seen. So that is a kind of end of the day discussions. What is a risk? Really, avoid. So, but, we had a lot of that type of questions, that in that case, the off-label use, which dose we can start from. And then we often go into the FDA reviews, and all, because we don't have any information sometimes, right? So that's why, that's, brilliant idea is to start from AKI studies, for example, but, at the end of the day, we got, questions, which dose we should start. In that case, and then we have to, proportionally, adjust the dose, what we should do, starting from. So something like that. So this is an example, about it, what the starting point that we need to, think about. That, that's my experience.
I think the other another issue there is assessment of GFR. Many of these kids are getting tons of fluids. Nobody's eating. Creatinine is off the charts in one way or the other, and cystatin C is responding to inflammation and everything, steroids that you give in the patient. So you have no idea really what your function is for the most part. So you have to be really careful about that. And you have no time to measure it either.
Very good point. Tom, earlier you had a slide around the agreement between creatinine clearance and indexed, BSA indexed, GFR estimation methods. Many older drugs or older labels have dosing recommendation in adults that are based on creatinine clearance, similar to this example that we're sharing. So I was wondering if the panel could discuss the limitations of or how we can translate data, dosing adjustment data in adults that are based on creatinine clearance to pediatric patients over 2 years of age. Clearly, we said under 2, we need additional data to make recommendations. In the over 2, what are the limitations of such approaches, and are there ways to minimize the uncertainties?
Well, I think you've done it here. So, you know, if it's a predominantly renally cleared drug, then I think this proportionality assumption is probably safer. And just like you've done here with the Ayvakaz label, I think you can probably do that with simple exposure, you know, modeling to exposure, you know, match. In my mind, where that starts to fall apart, it is if we get into non-renally cleared drugs or something that begins to have, you know, a greater degree of non-renal clearance that contributes to its overall elimination from the body. Then because of the underlying issues associated with ontogeny of the metabolic and transport pathways that also determine its clearance along with glomerular filtration, it becomes much more complex. But I think this is proof of principle right here, or at least a precedent that could be used to begin doing that.
So whether it's based on creatinine clearance or GFR in adults, we should be able to translate the data to peds over 2 years of age.
I think so. I mean, you know, if we purchase a car in Europe and the odometer, speedometer rather, is metric, we can still drive it in the U.S. as long as we translate, you know, to our speed limits. So you know, this idea that we keep focusing on whether it's an eGFR versus a creatinine clearance, you know, in some ways, I think we just need to think about the fact that we just need to adapt. We need to understand what it translates to from one to the other, and modeling can certainly help us do that, just like it did here, and just like it can with any drug for which we have older creatinine clearance-based estimates, I think.
Dr. Schwartz?
I would agree with you, except creatinine is secreted, and those people who got cimetidine in the hospital for stomach aches all of a sudden had rises in serum creatinine, but in fact their GFRs were normal. So I think this opens the question, what else is this patient on? Mm-hmm. Is he or she on drugs that are handled by the same organic cation secreting pathway? Mm. This is the kind of thing that, you know, makes it much more complicated. And even though it's, you know, handled by the kidney, in fact, the kidney does a few active things like reabsorb and secrete things. Mm-hmm. So one has to just be careful of that. We've had our biggest thing when we see the most acute kidney failure in our hospital, it's multiple drug administrations.
Jeff? Maybe just to follow up on your point, having said on the Therapeutic Standards Committee at a hospital, I mean, we might look at a table like that as provided in the label and say, all right, let's consider this. That doesn't mean that's what's going to go forward, but it could be the topic of discussion. What actually gets implemented may be something different. But if there's no therapeutic drug monitoring for these agents, then it's going to be outcome driven. So if you're the advocate for this at your institution, what do you put in place to give people confidence that you can do it safely?
Well, you need to know your medications. And, for example, we do know that if we administer amiloride to our patients, it may actually raise their creatinine, not because it kills the kidney, but because it inhibits secretion. Now, the drug, 268 medications that you approved, or whatever that period of time is, it'd be hard to keep up with that, but it could be computerized so that one could say organic cation, organic anion. This might be helpful. Many of the problems that we've had are in multiple antibiotic regimens, but then there's all these baseline meds that people are on also that will interfere with the metabolism or the secretion of these medications.
Other questions, comments? I guess maybe going back to the point that Tom made in his presentation regarding the need to individualize GFR or creatinine clearance. I think he made a strong case in adults that's reflected in the FDA guidance document to industry. I was wondering if the panel and the audience could discuss its applicability in peds. I think Shamir Tuckman cautioned around this approach in the smallest patients where BSA may drive the absolute value to be very low. So I'm just wondering if you could comment on what pediatric age groups would this be applicable to. This would be a major departure from what clinicians are doing, where eGFR values that are indexed to BSA are being used. So just wondering if you can comment. It doesn't have to be Tom. He presented his opinion. Saskia, I think you echoed his point, so if you want to start us off.
In my brain. I don't know. Actually, I don't have a clear answer right now. So maybe Tom.
Can I start?
Please.
Yeah, I'll start then.
No,
I don't know that my answer is clear either, but I mean, I think it's a difference between what the clinician will do at the bedside versus, how we do this research and how we collect the information. We got to use index. Every equation is 1.73 meters squared. I don't see how to do it any other way. We do have to inform clinicians and practitioners that this is the unit, so make sure you know what the patient's BSA is so you get the right, level. But I don't see that we should be changing what we just talked about in session one, because I think session one and what we've done as pediatricians forever and ever is to index the GFR.
Yeah, I think that does make sense. And in our hospital, and we don't have a lot of calculators in our electronic health record system, but we do have the eGFR calculator that takes the serum creatinine and the U25 and the SMAIDs, and actually comes up with these calculations. But also in our formulary, we provide these GFRs to give guidance on how to adjust the dosing in renal failure. So making this absolute would make it a bit harder. It would make it a bit harder. It would make more visible, like how low the kidney function is, if we would give absolute GFRs. But I think then everyone gets really confused.
Martina?
Oh, no,
go ahead.
So I think if we're saying in adults that it is really an individual's kidney function that determines, so say, for example, somebody is I don't know, 30 or something like that with 100 milliliters per minute, and their particular body surface area, if that's close to 1.73, then you're in luck. If that's closer to 2, then, or it's closer to 1.5, then you obviously, if you then sort of de-index, adjust whatever nomenclature you want to use, I'm sure there is, that runs the gamut, but then you're obviously going to get different values. So if we're saying that it is the actual individual's sort of capacity to clear that sort of should determine this, then I don't necessarily see why that should be different in pediatric patients as compared to adults, except for the fact that we only express this in these equations by 1.73 meters squared, because none of these equations realistically were developed for the intent of drug dosing. They were developed to be able to compare amongst patients, at least the way I understand it, to be able to compare amongst patients as to who actually has kidney disease or kidney disease, not necessarily renal impairment. I've always made a distinction between the two terms. I don't know if other people do that as well. I don't know. I think I've heard it used interchangeably today. But so then the question is, if we have I don't know, then you have, I don't know if you have 10-year-olds that have 100 milliliter per minute GFR. But if I have an adult with 100 milliliter per minute GFR, and I adjust that by 1.73 meters squared, and then I have somebody with, or better yet, the other way around, if I have a pediatric patient with 100 milliliters per minute per 1.73 meters squared, and an adult with 100 milliliters per minute per 1.73 meters squared, and now I adjust this for their body surface areas, and one is, I don't know, 1.6, and the kid is 1. Now the question is, you're going to make a much larger sort of adjustment then obviously to the kidney function, and I'm wondering if there is any data out there where somebody has looked whether or not that makes a difference, whether or not this would even be feasible to do. But realistically, I mean, if we're saying for adults it's the actual kidney function of that particular person, then that applies to pediatric patients too. I'm thinking the physiology doesn't necessarily change. It's just that we're so used to using these equations per 1.73 meters squared. So the question is, how much difference does that make?
Yeah, so I like to comment. We dose like 99% of our drugs in milligram per kilogram. And we have had big discussions with my colleagues from Leiden, and they would say, oh, that milligram, about the pharmacokinetics are affected by age, yes or no, or by body weight, yes or no. We had big discussions. And in the end, I said, I don't care. I want you to give me a dose in milligram per kilogram, because that's what we do. I cannot go back to my physician and say, oh, no, we published one dose, milligram per kilogram to the power 0.75 for morphine, which means that at different age groups, you have to give different milligram per kilogram doses. And so we published this paper. We published this table. We're using this. But if you're going to dose, if you're going to say give an advice on absolute clearance, renal clearance, then I get into trouble with my milligram per kilogram dose. It's really confusing, because if you use the milligram per kilogram dose, you already adjust it to the size of the patient, of the child. And then when you use these indexed GFRs, then you can say, oh, this child has 50 milligram per kilogram dose, which is just on base, and if I use this, then I know I have to give half. I go from 50 to 30, I give half. But if you give absolute, then I have to think, okay, but what is his normal GFR, non-indexed GFR? I have no idea, because I never calculate this. So yes, it makes way more sense, but no, it won't work in clinical practice, as clinical practice is now dosing. That was a long story to say a simple thing, sorry.
No, that's a really good point. Martina, did you have further comments on that?
No, I agree with you, but I was just trying to say, is there any data out there where anybody has ever looked?
No, but for adults, everyone assumes that adult is 1.73 square meters when you dose. So for adults, there's usually one dose. For kids, we already adjusted it to a chain difference in 1.73, that the kid doesn't have a 1.73 dose. And we do this by a different BSA, because we do this because we dose by kilogram or we dose by BSA. And that's the whole concept. I think for the adult world is kind of, well, maybe cannot say, maybe it's new that you cannot give everyone the same dose, because people are getting more obese and so much more obese that the 1.73 doesn't count anymore. I think that's a different, so we are kind of like ahead of you guys, ahead of the adult guys. And I think that's, well, so maybe we should start dosing by kilogram. No, I'm joking.
Dr. Short?
I agree with you. I think this is a good scale. It would work for over 2, but I think the obesity epidemic is making me rethink some of this, especially with drugs that are potentially nephrotoxic, that we've talked about giving ideal weights based on height. And I think there's something to be said for that, for many medications.
Definitely, yeah. Ron, did you have a question earlier? I feel like we skipped you. Did you? We still want to hear your question.
It's not really a question. It's more a comment along the lines that, not to insult my adult colleagues, but They are way behind pediatricians. I mean, the dose is a gram a day, okay? You're 200 kilograms, you're 40 kilogram, 60-year-old lady, the dose is a gram a day. And for us to pin what we do in pediatrics where we know that size matters and maturation matters, I think is something we should be very careful about doing.
Excellent point. Other comments or questions? Did we have any questions from our online audience? Okay. Oh, go ahead, Nick.
But just following up on one thing that Lynn had said, I think that GFR expressed per 1.73 meters squared is so wedded into the brains of pediatricians and pediatric nephrologists. If you're going to use any dose alteration scheme, it has to have utility, and it has to have utility at 3 o'clock in the morning. And I think if you start deviating and saying, oh, well, in this situation, you don't use corrected GFR, it is destined to fail. And however the research is done, I think when it comes to translation into clinical practice, it's got to be in the language that clinicians speak.
While I understand 100% what you're saying, and it takes an average 20 years for physician behaviors to change, I think we have to aim for the truth and not for the conventions that are being used. And I would actually expand that study, collect everything that you can, and use artificial intelligence to find out what are the parameters that actually get the drug dosing right. But it also brings up a question, and that is, for many drugs that we use, we don't know the exact therapeutic window. And so we also have to look at effect, right? Not just at the drug levels, not just, but we need to know, was it actually achieving what it needed to achieve? If I'm thinking about a child with hyperammonemia, we have a lot of Mennonite population, and we get at least 8 OTC deficiency a year, and we do now sequenced treatment. We start with hemodialysis to bring the ammonia down really quickly, and then we continue with CRT. I have no idea, even if I could get a benzoate level, what should it be, right? Or the amino acid cocktail that we give them, that is actually measurable, but I don't know what should it be to improve that. Also then, so I would actually have a very open mind about trying to find the truth and finding the model, and then look at strategies how to implement that in the clinical practice.
So I think we agree. I think we're saying the same thing. And I prefaced what I said by, yes, when you're collecting the information, absolutely do everything said. I was just talking about translating this into advice for the clinician. Yeah. So I think we agree.
And I think your questions and comments lead to our final question. Much of our discussion today has focused around the influence of renal impairment on drug disposition, but we also know that renal impairment can alter therapeutic response and toxicity. So as we think about the youngest age group with all the developmental and maturational changes, when should we think about dose adjustment differently because of concerns of toxicity or changes in therapeutic response? What are drug characteristics, disease characteristics, et cetera? What factors should be considered?
We did an interesting exercise with gentamicin the other day using this pragmatic PPK modeling, where we realized that our dose in neonates was higher than in all the kids. I was a clear cutoff at 4 weeks. We didn't understand. So then we started the model, and then it didn't make sense. But then someone said, why are we dosing this higher in the neonates? we have a higher exposure, and figured out that the bug, the bacteria that we are aiming for in these neonates is a different one than in other kids. So the MIC, the minimum inhibitory concentration, needs to be higher. So that's why we aim for a higher drug, and that's why we had this cutoff at 4 weeks. It took us all a long time, or not such a long time, but it was a kind of frustrating. And people would call us and say, hey, why is there this cutoff? Why, if that patient is 1 day older, I have to dose completely? So that's one thing that you need to take into account, even with simple drugs like antibiotics. Well, that's one thing. And diseases may still be different that we are treating. So, really good. There may be other people who have really good examples for diseases that are different.
That's a really good example, Saskia. Thank you. Vikram, you look like you wanted to.
Not really, but I was wondering whether, maybe a starting point would be to think about how we are dealing with the adult renal impaired population, and if we're dealing with that population differently, then that probably would apply most immediately. But if you're using the same extrapolation or target concentrations in terms of dosing recommendations there, then, I don't know why we would have to have very strong biological mechanism, whatever reasons to go down that path.
Thank you. Other comments?
I mean, in the end, to sort of add to what Vikram just said, even in adults, we make this assumption when we're matching the exposures, right, that it's similar, and I guess we don't necessarily have a lot of red flags, but I also am not sure that there's been sort of a systematic assessment on sort of which drugs. I think the DOAX usually is sort of like the prime example where we think maybe there might be differences, but yeah, even in adults, like I mentioned in the presentation, if you have exposure data or if you have PK data in some of your clinical trials and you have a sufficient number of patients with renal impairment, then you could at least test that assumption, at least in adults, and then see if you have something in pediatric patients. But then there is always the question, is that change in exposure-response relationship then the same between adults with renal impairment and peds with renal impairment? It's just layers and layers of complexity in that field, I think.
I mean, I think Dr. Schwartz has laid out in the discussion, at least for me, a lot of reasons why in that particular segment of age, everything could go wrong. I mean, I think that's real. But I actually don't know how else you start. But you have to start somewhere in making a first recommendation. And then the question is you collect additional data through whatever form and then see where it goes. But this approach is the only way to make that first recommendation.
Thank you, Vikram. I think people are getting tired and we're reaching the end of the day. Lynn did such a great job summarizing session 1. I didn't know she had some parting comments to summarize session 2, or we can just wait till...
No, I'll try, but you guys have to tell me if I didn't hear right. So I think that, let me just scroll back to my notes here. Yeah, so the topic of this session was specifically, how do we translate adult renal impairment data to pediatric patients with renal impairment? So that was what our goal was for this session. And I think what we heard was that under certain circumstances, that when we've established that the diseases are similar, that the responses to treatment on the efficacy side between pediatrics and adults is similar, then there's this window of opportunity. But that also, it doesn't stop there. So the second part is, what are the characteristics of the drug and that might affect differences in the translation from adult to pediatric renal impairment? The first I heard was that the closer you are to 100% renally eliminated without change is something that would give us confidence. The second thing I heard was that if you're over 2, that's better than if you're under 2. And the third thing I heard was, although I think Vikram clarified this, is that if there's a reason to be nervous about that translation for any reason, narrow therapeutic window, potential for drop in efficacy, like if you really need to have a dose that you are confident will be efficacious, that all of those things play into the potential for not being able to proportionally decrease, just like we did in the adults, where the adults had data to support that. So in those situations where we have less confidence, then it sounds like we're landing on the place that we got to probably collect data. And it sounds like tomorrow Jan is going to take us through, some situations in which those data could be collected. So that's firstly is when and how. And I think we also heard that there needs to be some sort of priority. Like it can't be just for every drug, for every, indication used in children, but there are probably priorities in which these data need to be collected if we can't just proportionally scale. Let's see, what else did I have? Oh, right. So in trying to figure out how to collect those data, I think I heard it could be done post-marketing. We could use clinical trial networks. We can partner academia, industry, NIH, FDA, and that maybe there's a way to leverage patients who have AK on the pediatric side to support what might be done to support the dosing and renal impairment, but with serious caveats that I think we heard about, firstly, the measurement of GFR and, in settings where it's changing rapidly. We already heard these estimating equations aren't great. What concomitant medications, the states of inflammation, the total fluid delivery, CKD on top of AKI, like all these things may limit our ability to actually do that measurement of GFR that's fundamental to what we would use then to estimate and I guess build in the model to create what dose we would use in pediatric patients. And then, see, I think that's all I have. And if I missed anything, that's about.
That's a great summary, Lynn, and she did this on the fly. So thank you. So thank you again to all the speakers for the great presentations, to all the panelists for the great discussions, for our audience who that engaged. We will reconvene tomorrow at 9 a.m. for session 3, which is going to be focused on the role of modeling and simulation. So enjoy your evening, and we'll see you back here tomorrow morning at 9. Thanks so much, and have a good evening.